Hi, good morning everyone. Assalamualaikum warahmatullahi wabarakatuh. Okay, welcome to Weekend Love with IAPMD second session. I'm Dr. Siti Zarka from HNLZ Kuala Terengganu. I hope you guys are healthy and fine and already had your breakfast today, because now we are going to listen to a very interesting topic that will be given by a renowned speaker. Let me introduce our speaker today by giving you a pantun. Okay. Pergi meminang anak maksiat, tapi terlupa nak bawa cincin. Beliau terkenal seluruh Malaysia. Itulah dia Prof Tan Geok Chin. Okay. Dr. Tan Geok Chin is a professor of pathology and consultant anatomical pathology at Faculty of Medicine, UKM. He received his training in anatomical pathology in National University of Malaysia and subsequently received his PhD degree in Imperial College London, United Kingdom, where he studied the characteristic of microRNA isomers in stem cells. His work led to the discovery of diverse function of isomers and their evolutionary importance, and it was published in Nucleic Acid Research. Subsequently, he completed the Pediatric Pathology Fellowship training in Nationwide Children's Hospital, Columbus, Ohio, USA. He is currently the Deputy Dean of Research and Innovation, a member of Medical Ethics Committee in UKM, and the Editor-in-Chief of Malaysian Journal of Pathology. He has received multiple Excellent Service Awards, 2007 and 2019, as well as Best Article Award from Medical Journal of Malaysia and Best Poster Award from Royal Society, Edinburgh. He is also a fellow of the Academy of Medicine Malaysia and holds a number of positions in the College of Pathologists and Malaysia Medical Council. He is also a member of the Credentialing Committee of Anatomical Pathology, MMC. He is a member of Education Committee and Continuous Professional Development, which is CPD, Committee of CPATH and AMM. He is the treasurer of the chapter of Perinatal and Pediatric Pathology, CPATH. He is Prof Tan, also a member of Perinatal and Gut Research Group. His current research interest is in pediatric and perinatal pathology, with a number of ongoing projects, namely gene expression of hereditary hormone, chorioamnionitis and its correlation with neonatal outcomes, and gut microbiome. Okay, without further ado, I would like to invite our speaker today, Prof Tan Geok Chin, to present his topic on Desmoplastic round cell tumor and its mimic. Okay, Prof, the floor is yours.
Thank you so much, Dr. Siti Zarka, for the kind introductions. Good morning, everyone. First of all, I would like to thank the organizing committee of IAPMD for the invitations. That's very kind of you for me to start the second seasons for this particular weekend's talk. Maybe a bit of advertisement for the Malaysian Journal of Pathology. So currently, the latest impact factors for our journal is 2.1 for the Journal Citations Report, JCR, which is a WOS Web of Science impact factors. And currently, the journal is in quartile 3. As for Scopus, the site score is now 2.3, and also it is in the quartile 3 category at the moment. So please support our Malaysian Journal of Pathology. If you have any interesting, especially original articles and review articles, please submit to the journals. For your information, case report now we have reduced in number a bit. We only accept up to like maybe 5 at the very most case report in each of the issues. So, but original articles and review articles will be taking very high priorities in the publications. So, okay, thank you. Sorry about the advertisement. Here we go straight to the. Okay, so what I'm going to do is, so this is basically malignant small round cell tumors topics today, talks. I'm going to start off with 3 interesting cases of small round blue cell tumors that metastasize to lymph node. So if you get just let's say the child presented just a lymph node, and this could happen if the clinicians did not manage to find the primary mass, and then they just biopsy the lymph node and send it to you, and you might be able to just get this lymph node, and you have to work out whether this is a small round blue cell tumors or not. And I have these 3 interesting cases that I can show you. And there's another last case at the end. If we have time, then I can go on to show you that. So let's jump onto this case number 1. This is a 6-year-old boy with the left supraclavicular lymph nodes for 1 month. He has prolonged fever, anemia, poor appetite, abdominal discomfort. Spleen is palpable, and the lymph node, the supraclavicular lymph node is about 2 centimeters in size. So we get this lymph node. As you can see, it's still residual lymphoid follicles seen in the background. But if you can see now, there are some fairly abnormal looking structures here and there, which at low power still may be considered as lymphoid component. However, if you go at higher magnifications, you can see now you have these sort of rounded things. Could this be glands? Could this be rosettes? Could this be something else? So I'm sure there's the lymphoid follicles here as well. So these are higher magnifications. You can see that now this particular rounded shaped structures has a central eosinophilic neural-like components within the lumens lights in the center. So what could this be? Is this glands? Could this be rosettes? Could this be lymphoma, metastatic Ewing's? As you know, Ewing's can have rosettes. Can this be metastatic adenocarcinomas because there's glands? Actually, could this be metastatic yolk sac tumor as well? Metastatic neuroblastomas? So feel free if you want to jump in and give your thoughts on this. It's going to be a 2-way discussions talk. I welcome anybody who wants to put in your input at any time. So subsequently, we did immunohistochemistry, and it's positive for synaptophysin CD56 and negative for Desmin. There are a few more markers that we performed, but I did not include in these particular slides. So jump straight to the diagnosis: malignant small round cell tumor with homocyte rosettes. So this is a pseudo rosettes with central neuropils. Background of neuropils are seen in certain places. Rare differentiating neuroblasts may be seen. It's synaptophysin positive, chromo positive, CD56 positive, Desmin negative, CD99 negative. So our diagnosis for this case is the metastatic neuroblastomas, poorly differentiated form. So second case, we have a 7-month-old girl, right inguinal lymph adenopathy for 3 to 4 months. I withhold some of the information that I will be giving it to you subsequently. If I give you those informations, then the diagnosis will be quite straightforward already. So I'm not going to give you the remaining of the history. I'll give you this later. So we get these lymph nodes, multiple lymph nodes actually, and also there's a mass, which we also get the mass at that time, just in case. Let's say they didn't get the mass and they just submit these lymph nodes to you, and what you get is, let's say, this particular lymph node, and you can see here over this region there is some abnormal looking cells that is infiltrating into the lymph node already at the subcapsular region. In higher magnifications, here again you can see there is this abnormal looking very large small round cells infiltrating at the subcapsular region, and again higher magnifications. So over here you can see some of these unusual cells, which I'm going to talk about it again later. So if you look at these carefully, what do you call this? What cells do you think it is? So rhabdoid-looking cells, rhabdomyoblasts, extended striations is some of the things that you want to consider. And at some other regions, you will see this particular pattern. This pattern looks like glands because it has this alveolar-looking pattern. So look like glands a little bit with sand. So all the cells at the periphery are attached to the surrounding connective tissue for fibroblast stroma, and in the center they are discohesive, and some necrosis within the center as well. So this is the alveolar-like patterns that we normally see in this particular tumor, and it can be mistaken as a gland. It can be mistaken as some other tumor as well. And so we have, is that neuroblast? Is that rhabdomyoblast? Is that glands? So our differential diagnosis at this point would be a metastatic alveolar rhabdomyosarcomas, metastatic neuroblastomas, lymphomas, and metastatic adenocarcinomas. So we did Desmond, which is positive. Our MyoD1 we did, unfortunately, was not working very well. It was not a nuclear staining, but eventually we call it as a metastatic alveolar rhabdomyosarcomas. So this is a complete history. A 7-month-old girl, right inguinal lymphadenopathy, right labial mass since 1 month old, and the mass measures 5 by 4 centimeter, multilobulated with mixed solid cystic component. So our diagnosis is a malignant small round cell, nest of cells with alveolar-like pattern. Mentioned this already. There is rhabdomyoblast, and it is eventually Desmond positive, MyoD1 positive. Right inguinal lymph nodes biopsy, metastatic alveolar rhabdomyosarcomas is our final diagnosis. And eventually, this should be further tested for molecular, for any FOXO and PEX translocations in order to determine where the aggressiveness of the tumors. The third case, this is actually not from our hospital, from other hospital, and very rare case that I'm going to talk more about in subsequent slides. This is a 12 years old male with abdominal pain and distension. There's a left cervical lymph node, loss of weight and appetite, diarrhea and vomiting, and I shouldn't be including this, intra-abdominal mass is present. So this is the lymph node that we obtained. It's almost entirely replaced already by the small round blue cells. It's actually not lymphoid tissues anymore. Very little lymphoid tissues remain, as you can see here. And this is the morphology, very sheet-like patterns, and some of the cells even have vacuolated or clear cytoplasms, and there's some fibrous stromas in between the tumor cells. You can see here some of the cells are mostly eosinophilic. Some do looks like got a bit of rhabdoid looking as well, and some are vacuolated. So quite a tough case at that time. So differential diagnosis, there's fibrous stroma, vacuolated cytoplasm, rhabdoid appearing cells. So it could be a metastatic desmoplastic small round cell tumor, could be metastatic E-ring sarcomas, metastatic alveolar rhabdomyosarcomas, rhabdoid tumors, metastatic carcinomas, all are in our differential diagnosis at that point. So eventually we did a panel of immunohistochemistry, and it turns out CD99 is like patchy staining, even though it's strong and membranous, but it's patchy. Desmin is also focal and patchy staining. CK, another focal and patchy staining. MyoD1 negative. So as you can see now already, it has some a little bit of myogenic differentiations, epithelial differentiations, and other differentiations are characteristic. There's no loss of INI1, myogenin, and is negative. And typically, the WT1 amino terminus and WT1 carboxy terminus has this selective differential expressions. So the amino terminus is negative, whereas the carboxy terminus of WT1 is positive. And this is quite characteristic of this particular tumor. So our diagnosis is malignant small round cell tumor. There's fibrostroma, variable immunohistochemical expressions, what we call as multi-phenotypic expressions. CD99 patchy, desmin focal, CK focal, MyoD1 negative, and differential expressions of WT1 amino and carboxy terminus. And subsequently, molecular testing was performed, and this is positive for EWSR1, WT1 translocations, characteristic of desmoplastic small round cell tumor. So our diagnosis is metastatic desmoplastic small round cell tumor. And the main tumor was also being examined, and the intra-abdominal mass show very similar morphology as well as immunohistochemical staining as compared to the cervical lymph nodes findings. So, if you do a break apart fish on EWSR1, then it will be positive as well. So you cannot use a break apart EWSR1 fish to distinguish between desmoplastic small round cell tumor and Ewing sarcomas, because Ewing sarcomas will be EWSR1 Fly1 translocation. So this is one of the papers that we recently published in Pediatric and Developmental Pathology. This we look at over a period of 23 years, and it consists of 10 desmoplastic small round cell tumors. And as you can see, over 23 years, there's only 10 cases from a children's hospital. So it's not very common. If you want to diagnose desmoplastic small round cell tumor, you have to think twice, and you must have enough evidence, because the case is actually rare. And if you diagnose this particular child with desmoplastic small round cell tumor, it's basically almost death sentence, because almost all of the children does not survive more than 2 to 3 years. So as I said, 23 years we go through, and only 10 cases, so 1 in 2 years. In UKM, I think so far I may have seen only 1 or 2 cases over the last 10 years. Okay, so almost all of them were confirmed with RT-PCR with a positive EWSR, WT1 translocations, and the age range between 9 to 28 years old, and this is basically a teenage disease with a male preponderance. Almost all cases have an intra-abdominal mass. This is something that I want to stress, although I put here 46%, but almost all the cases have, sorry, yeah, here, in all located intra-abdominal. This is the symptom, sorry. So all located intra-abdominal. So if you have a case that is extra-abdominal, like in the orbital region or somewhere else, and if you want to diagnose desmoplastic small round cell tumor, again, you need to be very careful in diagnosing that. I have seen one case where in the children's hospital previously was diagnosed as desmoplastic small round cell tumor in the orbit, but it was eventually turns out to be RT-PCR performing negative EWSR WT1 translocation. So you have to be very careful in diagnosing if it is extra-abdominal. It can metastasize to the lung, liver, lymph nodes, and bone. And this is the 10 cases that we published in the Pediatric and Developmental Pathology journal. As you can see here, all has, this one don't have information, but all the rest has some sort of abdominal lesions. And the age range is for us is 9 to 28 years old. Okay, and this in that particular paper, if you go and read about it, we basically compare 10 cases of desmoplastic small round cell tumor with 10 cases of Ewing's and about 10 cases of the Wilms tumors to compare between the WT1 amino and carboxy terminus immunoexpressions, how's the difference between them. And as you can see here, Ewing sarcomas, basically WT1A and C both are negative, whereas Wilms tumor both are positive. And desmoplastic small round cell tumors typically have these differential or preferential expressions of carboxyterminus and not the amino terminus. The reason is because of the EWSR1, WT1 translocations and giving rise to this particular staining pattern. Whereas Ewing sarcomas did not affect the WT1, it's an EWSR1 fly1 translocations. That's why the WT1s are not affected, and that's why it is not expressed. Okay, let's go to desmoplastic small round cell tumor a little bit more in detail. So this is the first paper published to describe desmoplastic small round cell tumor. Um, and they at that time they found that it has a divergent differentiations. It's actually similar to what we call currently as multi-phenotypic differentiations or expressions. So as you can see here, they say the immunohistochemistry has expressions towards epithelial, neuroendocrine, and skeletal muscles. But now we know actually myogenic expressions are not as common. So clinical features, children to young adults, 8 to 38 years old, and mean is 18 years old. Male predominance with a male to female ratio of 5 to 1. Usual symptoms is abdominal distension and pain and low back pain. Examinations, abdominal mass palpated in most cases, sometimes with ascites. So the same group who described the lesion first, Girard, also published a case series in 1991. So this is the information taken from there. So locations, majority occurs in the abdominal cavity. However, there are rare published cases where it can be outside the abdominal cavity. So those are the paratesticular, ovarian, thoracic, lung, intracranial, head and neck, and kidney. Behavior is extremely aggressive, like I said. It metastasis to the liver, lung, lymph nodes. A study of 17 cases, they followed 50 of the tumor within 4 years after the diagnosis. Actually, my internet is okay. There's a message comes out saying that my internet is a bit unstable. So I probably go a little bit slower. So this is the gross features that you will see if the clinician send it to you. You will see these nodules that attach to the peritoneal surface or the omentums, and they are solid, firm to hard in consistency because of the fibrostroma. They are gray-white in color, smooth, sometimes bosselated. Maybe here don't have a good one. Maybe here a bosselated appearance. Can be a huge, large mass with satellite nodule, and invasions to the surrounding organs directly can occur. Histologically, same like all other small round blue cells, they are small to medium-sized, round to oval in shape, hyperchromatic nuclei, inconspicuous nucleolite. Tumor cells separated by desmoplastic stroma. Uniformity among tumor cells. Usually uniformity is one of the features you see in the tumors with translocations. Numerous mitotic activities, necrosis, and calcifications. Some may have eosinophilic inclusions, like cytoplasmic condensations with a rhabdoid appearance that you see earlier and may be mistaken as rhabdomyosarcomas or rhabdoid tumors. That's why INI was performed in that particular tumor previously. Okay, this is generally the classical appearance of desmoplastic small round cell tumors. So you have these small to medium sized tumor cells infiltrating around and with a very desmoplastic stroma around them. This is some of the cases that we see over the 10 years of collections, the 20 years of collections. Some of the tumors are in the peritoneum, some in the small bowel, and they can infiltrate into the small bowel in a very subtle way like this, and doesn't really cause huge mass-like lesions microscopically that you can see clearly, but clearly you can see all these tumor cells are within the submucosa and causing a lot of fibrous or desmoplastic reactions there. This is in the omentum, the nodules that grossly we've seen earlier. And again, there's two components. You have these small round blue cells and you have a very desmoplastic stroma around them. In the lymph node, you see in the third case that I've shown earlier already, this one still have a lot, still have some lymphoid, residual lymphoid tissues left behind, but majority are also being infiltrated by the tumor already. Like for example, here you got the tumor cells and the lymphoid cells here. So this is the all the immuno that we perform in the cases, and they can express myogenic differentiations. So Desmin positive, they can express epithelial markers, cytokeratin and EMA. They can express neuroendocrine markers like NSE and CD99, and they are typically WT1 amino negative, WT1 carboxy positive. So immunohistochemistry, they have multi-phenotypic expressions. Positive in nearly all cases would be CK, EMA, vimentin, and desmin. However, they normally are muscle-specific actin negative like myogenin and MyoD1 negative. Positive in half of the cases are the NSE, S100, and CD99. So the defining features is the presence of these translocations of EWSR, WT1 translocations. So if you detect this, then you can safely say this is, although there are some very minor rare cases where there's some that doesn't fulfill this criteria, but almost more than 90% are all WT1, EWSR1, WT1 translocations. And these result in the chimeric transcript encodes aberrant transcriptional regulatory factors. So this particular translocations is a transcript that will regulate the phenotypic malignant phenotypes of the desmoplastic small round cell tumors. So this transcript actually regulates some of the genes, and some genes can be proliferations and so on. So just very quickly look at what's the differential diagnosis of a small round cell tumor. As I always said, use this mnemonic to remember all the small round blue cell tumor. Learn to swim. L stands for leukemia and lymphoma. E, Ewing sarcomas. AR, alveolar rhabdomyosarcoma, and neuroblastomas. S, synovial sarcomas. W is Wilms tumor. I is NIN loss. INI loss tumors. M is other miscellaneous, for example, desmoplastic small round cell tumor. And what's the differential diagnosis for desmoplastic small round cell tumor? So this is more of a morphological differential diagnosis. I only select this few is because most others have a more different in terms for their locations and also their age of presentations, whereas this has a more nearer locations and age in terms for their similarities. So one is Wilms tumor, especially the blasting predominant Wilms tumor. The triphasic Wilms tumors, basically we don't have any difficulty in differentiating or distinguishing them. Ewing sarcomas next. and then undifferentiated neuroblastomas. Again, the undifferentiated, even the polydifferentiated ones sometimes could be easier to diagnose already, as you can see in the previous one. You can see neuropeals, and you can see all those rosettes, pseudo-rosettes, homo-right pseudo-rosettes that has neuropeel within, and quite easy to differentiate from desmoplastic small round cell tumors. The undifferentiated one is the one that we are worried about. And the alveolar rhabdomyosarcomas, synovial actually may be taken out because the age is actually quite different from desmoplastic small round cell tumors. So as you can see, all of them can be intra-abdominal. For desmoplastic round cell tumor, Wilms, Ewing, alveolar rhabdomas, and neuroblastomas, all intra-abdominal. So so Wilms can be renal, extra-renal, Ewings, paraspinal, pelvis, chest wall, extremities, bone, alveolar rhabdomyosarcomas, skeletal muscle or extremity, trunks, and head, neuroblastomas, paravertebral regions. And the age groups are all fairly similar, and some overlap in between all these particular tumors. So very quickly, just to go through each of these four types of tumors, differential diagnosis with desmoplastic small round cell tumors. Wilms tumors, large majority is triphasic, mixed at 41%, and blastomal 39, epithelial predominant 18, stromal predominant 1, and this is WT1 and amino and carboxy positive. When you write your report, you need to put in these particular features, as the clinicians would use this for prognostications and so on. So like this is the triphasic patterns. You got your epithelial component, stromal, and blastomal, which is very straightforward. But sometimes you can have only the blastomal component predominant, and this sometimes can even look a bit like the desmoplastic stroma. Ewing sarcomas, this is small round to oval cells. Cytoplasmic vacuolations is one of the features, so this is one thing that you should pay attention to. If you see vacuolated cytoplasm, Ewing is one of the things that you should exclude. And usually it concentrates around blood vessels. And some neuropil features that you see sometimes can have rosettes. CD99, it should be diffuse, strongly membranous positive, and FLY1 positive. 90% will be EWSR1 FLY1 mutations, and 10% is ERG. So you can see here, Ewing sarcomas can have rosettes also, so that's why it can be confusing. It can't distinguish between neuroblastomas. They can have some pseudo rosettes like pattern. Okay, alveolar rhabdomyosarcomas. Again, just like what I've shown in the earlier case, they have these alveolar-like patterns where at the periphery the cells are adherent to the tissue stroma, connective tissue stroma, and in the middle they are discohesive. So small round cells, thin fibrous septa, loss of cell cohesion, alveolar growth pattern. You can see rhabdomyoblast sometimes, and cross striations in the cytoplasm sometimes. Not always, you can see this. And 60 to 85% have PEX3 FOXO1 translocations, and 15 to 20% have PEX7 FOXO1 translocations. Fusion negative alveolar rhabdomyosarcoma has a better outcome. So that's why this particular molecular study should be done in all cases of alveolar rhabdomyosarcoma. If your center is possible to do this study. Neuroblastoma, small round cell tumors, salt and pepper chromatin pattern of the nuclide, hemorrhoid pseudorosettes and neuropils. You'll see here there's some neuropils here and there. So this is typical of a polydifferentiated neoplasmomas. Just a comparison of all the 4 tumors that we described just now. And Wilms is the triphasic. Over here you see blastemo and the mesenchymal components. Alveolar sarcomas, you see alveolar growth patterns. And neuroblastomas, you see hemorrhoid pseudorosettes. And Ewing sarcomas typically has these vacuolated cytoplasms in most of their cells, malignant cells. So in summary, desmoplastic small cell cells, this is highly aggressive tumors. Survival is usually less than 2 to 3 to most 4 years. So once you make this diagnosis, it's almost like a death sentence for the child. No really treatments that can really eradicate. So it has to be very aggressive. The vast majority are intra-abdominal. So if you want to diagnose an extra-abdominal DSR-CT, you need to be very careful. Better to perform RT-PCR to look for EWS-R71 translocations, multi-phenotypic expressions or divergent expressions, differentiations is major descriptions for this. So it can be very tricky at the very beginning because you may find it is Desmin positive and suspect it could be something else. And it could be CD99 positive and leads you to the suspicions of an Ewing sarcomas. You will have to do a panel because it can be CK focal positive also. So you do a panel and you find that almost all the immunohistochemistry are positive. However, they are patchy and focal, and you have to be very careful in diagnosing that. And they can be amino and carboxyluminous positive, amino negative and carboxy positive. So this is one of the immunohistochemistry that you should perform in order to diagnose this particular tumor. So from there, this amino and carboxyluminous, if you have this selective differential expression, then you should think about doing the molecular study. So diagnosis is correlations with clinical morphology, WT1 immunohistochemistry, and molecular genetic findings. I have actually one last case, but it's up to Dr. Siddhizaka. Do you want me to stop here or I should go on? Because I'm given about 45 minutes.
I think we can proceed with another case, Prof, because
okay.
It's only 10:40.
10:40, okay. Okay, so this last case is an interesting case of small round blue cells that we seen previously. This is actually being described also in the publications that we recently done in the Desmoplastic small round cell tumors. And this is a 9-year-old female with a left groin mass. Needle biopsy of the mass was performed. Okay, this is what we get. Basically, we have these small round cell tumors and very desmoplastic stroma in the surrounding, and a lot of necrosis and higher magnifications. Before I go to that, I think I can see here that there's some blood vessels here, and the tumor cells are around the blood vessels. High magnification, you can see small round cell tumor with these fibrous light stromas in the surrounding. Another high magnifications, you can see some vacuolated cytoplasms here and there, and a lot of mitosis and apoptotic bodies. So our differential at that time was an undifferentiated small round cell with small to medium-sized nuclei, clear or pale eosinophilic vacuolated cytoplasm, fibrous stroma, cell around blood vessels, area of necrosis, and frequent apoptosis. Our differential diagnosis were desmoplastic small round cell tumor, Ewing sarcomas, alveolar rhabdomyosarcoma, Wilms tumor, neuroblastomas. A bit out, maybe, Wilms tumor, because of the location. So at this point, any takers? What do you all think? Anybody want to try before I go on to the diagnosis? This is a tough one because it's actually what a very rare case. Okay, so let's go on. So we did an immunohistochemistry. It turns out to be CD99 patchy, Fly1 positive. What do you think? So if it is CD99 diffusely membranous positive and Fly1 positive, Desmin negative, CK negative, our diagnosis will be Ewing sarcoma, isn't it? Then we will do an EWSR Fly1 translocation molecular testing. Then it should be positive for that. If you do an EWSR break apart, it should be positive for a break apart. However, are you confident to call this as Ewing? Now that the CD99 is actually patchy and focal like this, we subsequently did a few more immunohistochemistry, and it turns out to be S100 negative. And what is this rating? I cannot see my screen. So WT1 amino and carboxy terminus positive, but is at the weak and moderate sort of intensity and not strongly positive for both. Okay, so I saw the MyoD one is negative. LCA we did also is negative. So immunochemistry is CD99 patchy, Fly1 positive, WT1 amino positive, WT1 carboxy positive, Desmin negative, CK negative, MyoD1 negative, S100 negative. Molecular analysis negative for EWSR1 Fly1 fusion. And it is positive for SIG gene rearrangement and likely represent a SIG.4 gene fusion. So this one was eventually called as SIG.4 round cell sarcoma. So this is this tumor is mimic Ewing sarcoma clinically and histologically, but fail to show cytogenetic abnormality of Ewing sarcomas. I think that's all from me. Thank you very much, everyone.
Thank you, Prof, for your excellent lecture. So far there's no question from the chat box. So if anybody has any question to Prof Tan, you can either switch on your mic or you can just drop your question in the chat box. Okay, but what I can gather from your lecture is that small round cell tumor in children is quite difficult. It's actually very difficult to diagnose. And the mnemonic of learn to swim is very helpful. I find it very helpful. But I have one question, Prof. From your study or from the paper you published, just recently, is the desmoplastic stroma is always present in all small round cell, the desmoplastic round cell tumor. Is it necessary to have a desmoplastic stroma in cases of desmoplastic round cell tumor, or it can be absent in certain cases of desmoplastic round cell tumor?
Okay, thank you very much, Dr. Siti Zaka, for the questions. It is one of the features that distinct it from other small round cell tumor. As the name implies, it is a desmoplastic small round cell tumor. However, I think it is very variable. Some of them may not have a lot of desmoplastic stroma, so you may have certain region that does not have so much of the desmoplastic stroma. So I think if you don't see them, it does not really straight away exclude it from your differential diagnosis. I think that's my take.
Okay, all right. I guess you're true, because as you said just now, the morphology is polyphenotypic, right? Okay, there's some question in the chat box. There's question from Dr. Najah from Hospital Melaka. Hi, Prof. Thank you for the excellent talk. Do you recommend all complicated small round cell tumor to proceed with molecular analysis? For some cases, the morphology and IHC are overlapping.
I think not all cases. Some cases are straightforward. Like if you encounter, I mean, for diagnostic purposes, some cases are straightforward and doesn't require, then you don't have to. Like, for example, alveolar rhabdomyosarcomas with your Desmin MyoD1 is sufficient for a diagnosis. However, having said that, molecular is helpful in terms for the prognostifications, so you might require that as well. Some will definitely require molecular. One would be desmoplastic small round cell tumors, that which definitely require to have a molecular confirmations. However, having said that, I'm not sure whether most of the lab in Malaysia has this particular service yet to give this full force of molecular service. So I think it depends a lot on the lab. So if you suspect, do the immunohistochemistry first, discuss with your clinicians, and ultimately, if require molecular, you can always send to a center that can perform this molecular study.
Okay, I hope, Kak Najah, I hope Prof Tan answer your question. There's a question from Dr. Fazila Hassan. The question is, do we need to do WT1? I assume maybe in all small round cell tumor, I guess, because the question just said, do we need to do WT1?
So WT1, there is two WT1. That I'm not sure whether your lab will be, even UKM don't have WT1 amino and carboxy terminus, two different antibodies. We have the general WT1, which I think the general one is the WT1 carboxy terminus, if I'm not mistaken. The one that separate the amino and carboxy terminus, not many lab has it. If I think not many lab has it. The one I went to, the one that I presented are all from the hospital, the children's hospital that I went to. But if you can do it, will be a good thing. WT1.
Okay, Prof. Thank you for the.
If you look at that particular paper that we published, it has we look that the paper has all the SIGDUC4 rearrangement immunohistochemistry findings, and from there you can see a lot of the lab actually don't have WT1 amino and carboxy. Also, some they just do one of the immunostains. So that's why I think a lot of lab don't have these two stains.
Yeah, true, Prof. For my center, we have actually WT1, pan WT1 actually. So they cover both amino and carboxy. So for those cases, especially for small round cell tumor, desmoplastic round cell tumor, we really have to, send for molecular for confirmation.
Yes, so it will be, if you have a pan WT1 or a carboxy only, then it will be useful only to distinguish between Ewings and WIMS.
Yeah, true. Okay, thank you, Prof, for the answer. There's another question in the chat box from Dr. Nurul Akmal. In a low resource centers with limited IHC panels, what are the basic important IHC required to exclude mimicus of undifferentiated small round cell tumors, especially abdominal, or retroperitoneal mass? I guess this is a favorite question to all the speakers.
Okay, thank you for that questions. I suppose it's very difficult to say minimal panel. I suppose it's very important to identify what is the common children's related tumors that you see in your center. And that depends largely on who is your pediatric surgeons over there. And what they are comfortable in performing. If these are more towards, let's say, alveolar towards rhabdomyosarcomas and those sorts of tumors, then I suppose you need to have all those type of stainings in that center. So I know we cannot stock up all our immunohistochemistry and waiting for cases to come. That's what we are facing in UKM also. I don't have the cases when it's not many. I don't have the indications to say that I want to stock up all the immunohistochemistry, and it's not fair to ask for all those unless we have huge number of cases in that we know there's a huge number of cases of this type of tumor, then we can request to stock up all the immunohistochemistry. So I don't think it is one size fits all type of answer. I think it needs to depend on what type of tumors that you will normally see in your center, and then determine based on that.
Okay, thank you, Prof. Well, I guess in KKM Hospital, we can always refer to more resourceful hospital like HKL maybe.
HKL, yes. HKL, I think they have even the better immunohistochemistry than UKM.
Okay, there's another question from Dr. Salmi. Hi, Tan. Thank you for hi, Prof. Tan. For the last case, if we don't have molecular testing, how should we phrase the interpretation?
If you don't have molecular study, I suppose you need to say consistent with this particular tumors and put a comment saying that further molecular testing is required for confirmations. And if the patients or the center has the fund, they can actually send the thing for further testing from somewhere else, maybe from HKL or if UKM or even the private sectors or even overseas. So I think you should say consistent with and put a comment saying that molecular testing is required for confirmation.
Yeah, I guess it's true. Okay, thank you, Prof. Okay, so far there's no more question in the chat box. Maybe anyone want to ask the question directly to Prof. Tan? I guess there's no more questions.
Okay.
Okay, thank you so much, Prof. Tan, for your very interesting presentation. Okay, before we end this session, I just want to give a pantun to everybody. This is in dialect, Terengganu dialect pantun. Okay, jalang-jalang cari ikan di rumah abahmu. Salah silap harap dimaafkan. Bila boleh free, marilah teranung. Okay, that's all from me. Okay, thank you, Prof. Thank you, everybody. So I give the floor to organizing committee. Suguna, do you have any
yes
announcement?
Yeah, thank you so much, Prof. Tan, for the wonderful excellent talk, incorporating from the clinical up to the molecular aspect of the desmoplastic small round blue cell tumor, and also Prof. Tan touched on the mimicus of the undifferentiated small round blue cell tumor. It was an excellent talk. I hope all of us benefited from this talk. And thank you so much to Dr. Siti Zarka for being our moderator for today. And on behalf of the committee, IAPMD Weekend Committee, we would like to extend our thank to Prof. Tan and also Dr. Siti Zarka And before we end this talk, I would like to inform to participants that the certificate and the NSR CPD for this talk will be shared to all the registered participants in the future, in near future. And for those who haven't registered for the upcoming talk, kindly do so, and please visit our website, IAPMD Malaysian Division website, and registered. And now we have opened our platform into a live Facebook, and subsequent talks will be in live YouTube channels. So we have both Zoom and also YouTube channel for the subsequent talks. And I'm also glad to announce that our coming talk will be on 15 October 2022, will be based on neuromuscular pathology, with introduction to neuromuscular pathology by Dr. Suryati Muhammad Yusuf. With that, I would like to end this talk, and thank you so much again, Prof Tan and Dr. Siti Zarka. Thank you all, and thank you to the participant.
Thank you.
Okay.
Thank you for thank you, Nurul.
Thank you, Prof Tan. Thank you, everybody.
Thank you.
Thank you.